So, good evening, dear friends. On the behalf of Indian Society of Critical Care Medicine, I welcome you all to this next webinar, New Strain, New Challenges and Way Forward. Today, we have got very illustrious faculty amongst us. I welcome you all, sir. Dr. R.K. Mani, he is Director, COVID Manager, Pulmonology and Critical Care, Yashoda Super Specialty Hospital, Ghaziabad. Sir is also a past President of Indian Society of Critical Care Medicine. And as you have already heard, he has written many books and chapters in different forums and published too many papers. He was the chief editor of Indian Journal of Critical Care Medicine earlier also. Dr. Andrew Conway Morris is MRC clinician scientist, University of Cambridge, honorary consultant in intensive care medicine at Edinburgh Hospital, Cambridge. He is also the deputy chair of infectious section of European Society of Intensive Care Medicine. Dr. Subhash Todi, he is a medical advisor and director of critical care at AMRI Hospital, Dhakuria and Mukandpur, medical advisor, AMRI Group of Hospitals, Kolkata. Sir is also the chief editor of our annual update and is also editor of our textbook of ISCCM. Dr. Vivek Nagia, he is principal director and head intensive care of respiratory critical care and sleep medicine at Max Hospital, Saket. He is very active in infectious disease. Dr. Ravindra Mehta, he is chief of critical care, consultant pulmonologist, sleep medicine specialist at Apollo Hospital, Bangalore. Dr. Om Srivastav, he is consultant infectious disease and HIV medicine at Jaslok Hospital and Sir HN Hospital, HN Reliance Hospital, Mumbai. Dr. P. Vishnu Rao, he is infectious disease specialist and consultant at Department of Infectious Disease, Apollo Jubilee Hills. Dr. Manish Bharti, I can't see him, he is about to join. He is consultant intensive care in charge at Prince Sultan Cardiac and Research Center at Dubai. And our moderator for today is young dynamic Dr. Srinivas Samvedam, who is the head of critical care and medical director at Virinchi Hospital, Hyderabad. He is currently vice president of Indian Society of Critical Care Medicine and also an associate editor of Indian Journal of Critical Care Medicine. Dr. Manish Bharti has also joined. We have got one visitor today, Mrs. Ritu Sharma. I welcome her here. She is from Indian Express newspaper. So thank you very much. Without wasting much time, I'll request Dr. Srinivas Samvedam to carry on.
Good evening, sir, and thank you for the introduction and facilitating this panel discussion at the outset. I'm grateful to the Indian Society of Critical Care Medicine for giving us this opportunity of sharing our views and thoughts on this, what seems to be a question in everybody's mind. Is the third wave going to happen? If so, how and what are we going to be in for in the next couple of months? Maybe some countries are already facing it, but we are probably looking at what's going to happen in a couple of weeks from now. So the topic is new strains, new challenges, and the way forward. My panelists for tonight have already been introduced, and we will start the session for today with the first question to Dr. Subhash Todi. It's a basic question. It's the first ball of the test match. So what exactly is a variant? You are saying the Delta variant, the Alpha variant, and a couple of others as well. What exactly is a variant? And there's terminologies which are floating around of a variant of interest and a variant of concern. So what would be your relevance? What relevance would you place on something that's just a variant of interest and something that's gone on to become a variant of concern, sir? Dr. Todi.
Thank you, Dr. Srini. I think this nomenclature has become very important, and we should be always be cognizant of what these mean. The WHO and CDC have got three nomenclature. One is VOI, variant of interest. One is VOC, variant of concern, and VOSC, variant of high consequences. Basically, as you know, that the COVID virus is an RNA virus. Its whole genome has been sequenced. Now, a lot of variants and substitution and has been noted, but most of these variants do not have any clinical significance. So only a few variants, which are mostly substitution in the spike protein, they become a variant of importance, you might say. And that is what the first thing what has been found is the variants of a initially importance, and from there on, as the spread is increasing, it becomes variants of concern. And when the spread is so much that that becomes the predominant variant, then it becomes variant of high consequences. So basically, a strategic mutation in the genes which causes changes in the spike protein at certain subunits of the spike protein make it importance in increasing transmission, increasing severity, or immune escape phenomena like vaccines not working, or having second infections and having tolerance, the plasma not working, or for monoclonal antibodies not working. So those are the concerns of these variants. Over to you.
Thank you, sir. So we'll take this across and we'll take it forward to Dr. Mani. Sir, we have seen variants of different viruses in the past. We have seen, I mean, dengue used to create havoc in this country till about a couple of years ago, and now we have forgotten about it. The initial SARS pandemic also had a lot of variants going around. The Ebola virus had a lot of variants going around. Why is it that the SARS-CoV-2 variants have attracted so much attention and we have become paranoid about these variants while we just got on with it with other viral outbreaks in the past? Why is that the COVID virus, the COVID-19 variants have now attracted so much attention that it's warranted a panel discussion?
Because we are once bitten, twice shy. You see, after the first wave, there was a lot of complacency. Although there was an inkling that it can come back, and it did in this country with a vengeance. Not only in this country, in many countries. UK has gone through a very bad time, and it's still continuing. And so did US, and so did South Africa and Brazil. So why did that happen? I mean, even though many of these countries, like UK, the vaccination drive, US vaccination drive was on since November. And yet they had a big surge in the turn of this year. And we had a very bad turn, starting in February and peaking in April and May. And then we discovered that this was due to the variants. You see, in the US, there will be 1.1.7, the alpha one. But in India, we witnessed the Delta virus variant. Delta variant, B.1, 617.2, right? 61.2. And then 61.1, which is a kappa, which is less lethal. We discovered that some of these variants, which are labeled as variants of concern, they are not, we cannot but take cognizance of the fact they are going to impact very heavily the public health planning we have had, what we have mapped out, and all the measures we have taken. We have to revisit them because they seem to have many things. Firstly, the transmissibility has increased tremendously, suddenly. The R0, RO increased up to 3.4, 3.5, or even 4. And then the lethality increased in terms of the hospitalizations and the mortality. We witnessed it in our country. The younger population were affected, and we also saw that vaccinated individuals were getting infected. A lot of our colleagues, our own frontline workers, got infected, and some of them very seriously, and some of them even died. Although the proportion is small, but this was an eye-opener for us that there can be escape of all the measures that we have taken in terms of even diagnostics were affected. A lot of false negatives in the RT-PCR. And then our therapeutic measures, as Subhash mentioned, that it could escape the effects of monoclonal antibodies, there's the efficacy of monoclonal antibodies or convalescent plasma. So we can see that the impact is on the surge is mediated by a variant of concern. This is a dynamic process. Now, this VOC was Delta this time. There is already the talk of Delta variant, the Delta plus variant. And although it's small and it's not yet declared a variant of concern, there are early rumblings which may just escalate. We do not know. So the vigil has to be continuous. We have to do genomics, we have to share genomics, and then we have to track and trace all the time and identify, characterize these variants. So I would say that it is not a question whether we are going to have a third wave or not. I think it is in all probability it will be there. We have to mitigate its effects. We have to make it a ripple rather than a wave. And so knowledge of all these factors will enable us to respond scientifically and adequately.
Thank you, sir. So we bring in our young infectious disease specialist here, Dr. Vishnu Rao. Dr. Vishnu, how do you think, or what do you think will be the major change in the infectivity of this virus based on the different variants, the alpha versus the delta plus variant? What would be your take on its infectivity, its transmissibility, and its pathogenicity?
Yes, sir. When it comes to the infectivity, definitely the infectivity has been increased, sir. When the virus has first started, when it's a wild strain, the R0 was around 2 to 2.5. In fact, if we compare it with the flu, what we had before, it was around 1.3. So the wild strain which we had in the beginning was around 2 to 2.5. Then the alpha variant, it further has an increased transmissibility with the R0 of almost 4 to 5. But now the delta variant, the studies or the report says that the R0 or the infectivity is up to 5 to 8, which simply translates to a single person can infect 5 to 8 susceptible patients. So definitely the virus, the transmissibility has increased. There is no doubt about it, number one. Number two, as the virus is mutating, it is evading the immune system. But however, still our vaccines are fair enough, though the neutralizing ability of the antibodies has come down, but they not have come down to a significant extent. And still the vaccine works. This is something good about it. And when it comes to the severity, definitely we have data to say that the alpha variant, if you look into the alpha variant, definitely it has more severity and more mortality. When it comes to the delta variant, there is some controversy where few of the studies are saying that the severity is more and the death rate is also more, but there are certain other studies just saying that it's just an extrapolation of the increased number of cases which has actually translated into the increased mortality rather than a true mutant related mortality. So that is a lot of experts are saying maybe the severity or the mortality is more, but definitely there is increase in the transmissibility, yes, immune invasion, yes, but still the vaccines are working. When it comes to the severity, still there is some doubt. Yeah.
Thank you, Dr. Vishnu. So we now go to Dr. Mehta, and he is in the forefront of seeing these patients who come to him with the symptomatology. He's seen the first wave, he's seen the second wave, and he's now waiting for the third one, right? So, Ravi, what does the symptomatology, how does the symptomatology change with the Delta variant? Do you think the symptoms of the Delta variant are different from what we saw with the Alpha variant, or it's just, as Vishnu said, just because more number of people are coming in with the infection, we are picking up the less common symptoms are being now noticed and being recognized? What is your take on that?
Yeah, so I think that's a million-dollar question is, which lay people and everybody wants to know, is that does the variant have a clinical correlate? And I think we're struggling with this from the beginning, that right from the interesting Greek alphabets alpha all the way to delta plus and going on to kappa, lambda and epsilon, we don't have clinical correlates. And it's very logical that first of all, you have to identify the deltas. We've been lagging behind in genomics. Then you have to go back to the deltas and see what those patients look like and whether there were clinical correlates, and then try to put a phenotype which will be helpful to you and me. So that's not happened. So whatever we know of these variants right now with the limited data available is that, as Vishnu said, highly infected. This time we saw that families went out like completely at this point, more than a huge hit rate, 80% plus was a ballpark figure. By the time one person got an infection, you even isolating may not have helped because all the others were already infected. So that -2 to +3 syndrome of infectivity, which happens in COVID-19, was exemplified manifold with Delta, with the current wave, which is extrapolatable to Delta. The second thing is the fact that when they hit our hospitals, the death rates and all have been high, probably because of the overwhelming speed with which it came. So the acceleration of the people it afflicted probably affected us more than being more infected. That is the current, being more lethal is the feeling at this point. So we have nothing to suggest that beyond overwhelming healthcare, it has an independent attributable mortality by itself, at least as per current knowledge. The third most worrisome thing is, which all of us are wondering, is that epidemic following the pandemic of mucormycosis, has it got anything to do with this variant? Because the entire question asked is why India, why not in the first wave, and so on. So those are a multitude of reasons. The viral variant aspect has been brought about, again speculation, but not totally answered. So this is where we stand at this point with the Delta infectivity part of it. One of the most interesting things, Srinivas, I'll take one more minute, is this new thing which came from NIV Pune, that when they studied 677 samples now, I think 80 to 90% have been Delta for breakthrough infection. So double vaccinated guys who hit the hospitals, most of them have been Deltas. However, 10% only were hospitalized seriously and less than 1% have died. So it clearly shows that breakthrough infection, which is infection despite vaccination, though it is happening with the Delta variant, is at least not leading to an overwhelming high mortality, which is a very reassuring thing. In our own data also, we found the same thing. Out of the first 500 patients, 148 are vaccinated, and most of them are single vaccinated. And the single vaccinated people in our cohort have got less severity of infection, less CRPs, and less need for respiratory requirement despite having comorbidities, because most of them are single vaccinated. So this entire conundrum tells us highly infective, rapid spread, overwhelms healthcare, probably will cause more breakthrough infections despite vaccination with the current vaccines, but may not be independently more lethal, except for that tinge of mucormycosis and fungal infection, which is lingering in our minds.
Thank you, Ravi. So we go to Manish, who is actually in a part of the world which has reimposed travel restrictions for passengers coming from the subcontinent. Basically, looking at the Delta variant being originating from the subcontinent. Manish, what strategy change would you see or are you seeing when managing the mild to moderate infections, which are probably or hypothetically being caused by the Delta variants? Have you made any strategy change from what you saw in the first wave and the lessons learned from the first wave? And how have your strategies changed when you are dealing with somebody who's supposed to be infected with the Delta variant?
Yeah, thank you, Srinivas. Thank you for giving me a difficult question. A lot of things are based on conjectures and suppositions. Given the fact that nobody has seen how the implications are going to be with this variant. I personally believe, Srinivas, that most of the things are going to be of the same standard. What we have need to be advised or need to be advocated for, the second wave per se. However, I can see that in mild to moderate cases, maybe the use of monoclonal antibodies is going to be much more used by the reasons that now the evidence is percolating for the use of this kind of a treatment regimen. Having said so, I particularly don't see any specific difference. Yes, we do understand the lot of infectivity is going to be high, especially with this kind of a variant, and whatever the the data we have on the basis of the understanding, we expect that the case fatality ratio is going to be high because of one or another reasons which we need to think upon. At this point of time, I think Srinivas, most of the things are going to be of the same the standards. At least we should not do anything different, except the fact that whatever the standards which we have been able to do in the second wave, at least those kind of standards, they need to be continuously on.
Thank you. Thank you, Manish. We'll go across to where the action is currently happening, and that's in the United Kingdom. and we bring in Dr. Conway into the discussion. What we hear here in India is that the NHS has actually asked its doctors to work extra shifts and come back for work, even on their days off. So probably that's a warning sign that the wave has already happened, and in all likelihood they are seeing the Delta variant swamping the ICUs. So it looks likely that the United Kingdom is actually seeing severe and critical infections caused by Delta variant. So Andrew, what would you tell us about the severity? What are you seeing as the difference in the spectrum now to what you saw in the second and the first waves? And how has your treatment strategy changed while you're managing this severe and critical patients with probably the Delta variant infections?
So thank you very much for the question. I mean, you're absolutely right that the UK is in the middle of our very definitely third wave, depending on how you count the previous ones. And this is overwhelmingly caused by the Delta variant, and that is clear. We're in a very interesting position in that we now have a substantial proportion of the population vaccinated, and particularly with having started with the oldest and most vulnerable patients, what we have is about half the population vaccinated, and with that disproportionately, and that's fully vaccinated, so having had 2 doses, and with that disproportionately weighted towards the older and more vulnerable groups. And so what we're seeing is we have a current case rate of about 50,000 new cases per day, which is the highest in the world and not something to boast about in any way at all. What's interesting is, though, that high rate is not translating into the sorts of pressure that we had in the hospitals in January when we had wave 2, which was almost exclusively caused by the Alpha variant. Now, I don't think this is because the Delta variant is any less virulent. I think it's because it is disproportionately in the younger people who have not been vaccinated, and that when it is infecting older people who've been double vaccinated, not all of them are getting severe illness. And what we know is that both the AstraZeneca and the Pfizer and BioNTech vaccines, which are the 3 that have been widely used here, although they have reduced efficacy in preventing symptomatic infection, and indeed our Minister of Health was tested positive yesterday, having had both vaccines, but we do see that they remain protective against severe disease. So I think that's reassuring. Now, clearly, the problems come when you've got a small percentage of a large number of people. And I think that's what we're experiencing now, is that we are definitely seeing COVID cases coming into hospital. They're definitely coming to ICU. As always, it's patchy around the country. Different places are affected differently. But those areas that have been most hard hit are seeing, significant numbers of patients who are becoming critically unwell and are coming to intensive care. To be honest with you, the biggest problem in the UK now is not the overwhelming wave of COVID that we had in January, where the National Health Service essentially became a COVID-only service and it did nothing else other than manage COVID in December, January. What we're seeing now is the pressure that comes from trying to run normal services, dealing with the run-of-the-mill illnesses and trauma and everything else that the health service is there to deal with, and also trying to deal with the additional load from COVID. And because it has spread so rapidly, I agree with the other panelists, the Delta variant clearly is more transmissible. I also agree that haven't seen strong signals that it's more virulent, that it's causing more severe disease. It's just we're seeing a lot of it, and therefore, as a result, those patients are percolating over. We are in England, particularly, and the UK is constituent of 4 different countries. But in England, from tomorrow, we're about to see the removal of pretty much all restrictions in the face of rapidly rising cases. Now, clearly, none of us have got a crystal ball and can predict. I have to say that amongst myself and my colleagues, and I think the sort of wider medical establishment, we all think this is absolutely crazy. It will be a fascinating experiment for those outside of the UK to watch. I'm sorry that once again we appear to be in the middle of a cautionary tale. But it will be interesting to see what's happening. I think we can look at Israel for an example of a country that's got high rates of vaccination and is also seeing resurgences. And it's clear that vaccines are not going to stop this disease completely. What we can hope, however, is that they are going to reduce the severity and reduce the pressure on the health service. But I fear that we're going to be living with COVID for a lot longer than perhaps we might have hoped in the early days.
Thank you. Thank you, Andrew. So we now go to someone who's got a profound understanding of how, the immune system and the body response and what we have in store. I bring in Dr. Om Srivastav into the discussion, and we'll ask him, sir, do you think that the Delta variants would differ in the host antibody response? We have seen that, the vaccines are not going to protect them from getting infected. So would the different variants, the Delta and the Delta plus, differ in the antibody response, or the host antibody response? Does it, have any effect on the infectivity and the clinical symptomatology of these patients?
So first up, thank you, Dr. Srinivas, for this opportunity. Very, very important question that you're asking. Will the antibody response and therefore the immune system response differ? Yes, it will. I think we don't know enough about what COVID is doing to the immune system. We already know that there is some part of at least the messenger RNA, at least the vaccination part, that is going to impact upon how the RNA system of a patient behaves. Already we are seeing that, not just with the immune system and the T cell dysfunction, but also with the B cell dysfunction, the natural killer cell dysfunction, the complement and the immunoglobulin dysfunction. All of these numbers are abnormal in patients who have recovered from COVID in the first 6 weeks, then 3 months, and 6 months, and 1 year's time. I'm talking about COVID starting last year. So we know that they don't follow standard patterns of other viral infections. We are looking at publishing our data. We don't have all the information that we need right now, but we are getting there. We're getting there. Will the antibody response differ? Yes, it will. I think that as has already been said before by eminent speakers before me, the antibody response and the spike protein response are going to be variable. If you look at the mutations that have already been described, there are a number of them. And if you look at other evidences that look at whether the virus started from, whether it was man-made or not, that has also looked at some very detailed study of spike proteins, and that is also in a state of disarray. There's no clear guidelines as to what the antibody and therefore what the spike proteins are doing. All of these numbers are behaving a little differently than what we would expect normally. So I would think that yes, there is going to be a dissociated antibody response, and that what we are going to be able to measure is also going to be very variable depending upon what kind of equipment we are using, because ultimately these are technologies that are dependent upon what technologies that you are going to be using in your laboratory. So a lot of the immune system calculations of how your patients have done, we are also seeing, as I'm sure everybody else is seeing on this panel, we are also seeing people who get COVID, go home, and then come back with clots in their lungs or legs or in their mesenteric vessels or in their brain, in their spine, in other parts as well. And these come about 2 or 3 months. Now, coagulopathy is probably related to an unstable endothelium, but that is coming out of a number of ligands that come because of a dysfunctional immune system. So I think that the key, when we say antibodies, I think that the key still rests with the immune system. Which part is going to be dysfunctional for how long? We don't know. I think we'll know more as time goes on. If there are other variants besides the Delta and the Delta plus, if there are other variants, we know that in the initial part of the second wave, the initial number of variants came from Kent as far back as September, October of last year. And that the immune dysfunction in those parts and therefore the antibody responses were also very variable. That has settled down. But of the other variants, the Delta variants and the other variants of the rest of the world, as to when they will manifest and how long they will stay in a patient system, difficult to say. I think that the question that you've asked is probably the matter of a debate or a continued medical education for a whole day or a couple of days. But to answer the question in one word, in one line, I think we don't know enough. Difficult to make a very, very detailed discussion on antibody responses and immune system, but we will know more as time goes on.
Thank you, sir.
Dr. Srinivas.
Yeah, thank you. So, Dr. Vishnu, now there is a decent population or a decent cohort of our population which got infected in the first wave, maybe in June and July of last year, and they would probably feel that now they have weathered the storm and they don't have a risk of getting this infection. Some of them might have get vaccinated as well in the interim period. So what is the risk of reinfection with the Delta variants in those who are infected with the Alpha variant in the first wave? What do you think would be the situation? Do they still need to be cautious about getting infected with the Delta variant?
Yes. Yes. At least we don't have specifically the data in respect to the Delta variant, what is the reinfection. But at least if you ask practically, the number of cases, what we've seen in the second wave during, this particular second wave, we did not see much of the reinfections as such. If we look into the data, I think there is one Danish study which has been published, which has looked into the number of people who got infected during the first wave and then into second wave, where they look, the data clearly said that those who are uninfected in the first wave, I think 3.5% of the people actually got infected. Those who are already infected, the number of people got infected in the second wave was around 0.65%. So they calculated and they said that the first wave protects 80% of the time. It protects from having a reinfection, and that falls to around 47% of the time in around of somebody who is more than 65 years. So this is the data what we have available when we look into the it's a long based on the huge population. And the other one what we have is based on the symptomatic patients. The Qatar study which clearly showed that those who actually had symptoms, those people who have COVID and who are symptomatic, the chances of reinfection what they calculated was only 0.2%. But there are lots of problem with these studies, because in the first wave, majority of the time at that time, the testing was an issue. A lot of people were asymptomatic. A lot of people weren't being tested. So we clearly don't know. But at least if you ask me grossly, the chances of reinfection are not very high. The data says that at least in symptomatic patients, it is less than 1%, up to 0.2%. And that's what it is there. But I would say definitely is less than 1%. If you ask me in terms of data, symptomatic patients, at least only 0.2%. This is the data what we have. But we don't have specific data only pertaining to Delta variant.
There is a question that's come up in the chat box, which I would probably request Dr. Om Srivastava to address this question. The question is, once infected with COVID, for how many days does it provide protection from reinfection? Is that an entity at all, or we can't say that as of now?
That's also difficult to answer. As to how many days, that would be variable from anywhere from 6 weeks to about 3 months, 4 months at the most, I would say, from what we have seen. Of course, you would need to quantify this kind of infection through a test. And whether it's a second infection or a reinfection is actually going to be depending upon genomic studies, which is something that we are just beginning to warm up to. The total amount of genomic studies that we are doing in India is anywhere from 0.5 to 1% of the people who are infected. That will have to be going to a much higher number before you can say, is this a primary infection? Is this a fresh infection? Is it a reinfection? Or is it something that is just showing up? So it's a little difficult to say unless you've got genomic studies. Everything else is probably conjecture and speculation. So to answer the question, well, it would be anywhere from 6 weeks time to about 4 months time at an average, maybe a couple of weeks more or less as compared to these figures, but that would be a ballpark figure that would be acceptable.
Okay. Sir, I'll stick with you and ask you the other question. Now, there would have been some patients who got infected in the previous waves, and they would have got their antibody titers measured several times out of their own interest or for any, for various reasons. So if they had pre-existing antibodies from a previous infection, would you think they would have some protection with the Delta variant? Would they have a milder infection, or doesn't make no difference?
So it's not only the antibodies. You need to have neutralizing antibodies. Of the neutralizing antibodies, you need to have antibodies which are 20% of your IgG component, and these neutralizing antibodies need to be in your system anywhere from about 9 months to 12 months if they are going to persist in your system and offer you protection. So I'm not sure, because unless we measure a neutralizing antibody, I'm not sure if a lot of laboratories can do that. Unless we measure a neutralizing antibody that can be quantified, again, the rest of the numbers are are very superficial and again speculation. So until such time as we actually measure neutralizing antibodies and we quantify them as to what percentage of the IgG component of the antibodies is there in a patient system, you are only going to be speculating as to how long that kind of antibody is going to be protecting you. They may not be IgG antibodies at all. And in that case, they are going to be offering you no protection. So you need to have, actually what happens now is that we send these numbers to reference laboratories in patients where the COVID test is positive for any more than 2 weeks or 3 weeks, which is beyond what we expect. There are patients who got COVID tests that are positive for up to 3 months. Now you can't keep them hospitalized. So once your patient crosses 4 months time and continues to have COVID tests, you need to send these tests to a reference laboratory to find out if there are indeed COVID tests that are positive because of lack of neutralizing antibodies. So it's got to be a balance of what you are doing and testing, but it must be a neutralizing antibody of a certain number, which is 20% of your patient's IgG, before you can say that it is safe and this patient is not going to get infected again.
Thank you, sir. So recently we've had the release of the monoclonal antibodies in the Indian market, and a lot of hope and a lot of optimism that this is the wonder drug, this is the magic bullet we have been waiting for to prevent the infections getting bad and patients getting onto oxygen and getting into hospital. So we bring in Dr. Vivek Nangia now, and we will ask him what will be the effect of these monoclonal antibodies on the new variants. Would you think they would be effective, or what is your take on the whole efficacy of this group?
Thanks, Dr. Srinivas, for asking a very interesting question. But before I go on to answer it, I'd want to tell the audience that basically the SARS-CoV-2 virus has this spike protein, which is composed of two subunits, the S1 and the S2. The S1 unit contains a receptor binding domain that recognizes and binds to the host receptor ACE2, and the S2 subunits basically mediates the viral cell membrane fusion and allows the entry of the virus into the cells. Now, we have got 4 antibodies that are monoclonal antibodies that are available, out of which 2 are available in India right now, the casirivimab and the imdevimab combination. And these 2 simultaneously bind to the different regions of the viral spike domain without interference and blocking the virus from binding to the ACE2 receptor. So they basically prevent the entry of the virus into the cells. Now, we don't have any large-scale studies to actually see the effect of these monoclonal antibodies on the Delta variant, as it's a new variant and it's still under evaluation. But in April 2021, the scientists from the Pasteur Institute, France, they isolated the Delta variant from a nasal sample of a patient who developed COVID-19 a few days after returning from India, and studied the therapeutic monoclonal antibodies, the serum from the serum samples from people who had been vaccinated or had been previously exposed to SARS-CoV-2. And they found that serum from the convalescent patients were 4-fold less potent against the Delta variant, serum as compared to the Alpha variant, serum from people who had been vaccinated with 2 doses of Pfizer or AstraZeneca vaccine, they neutralized the Delta variant quite well, although the efficacy was slightly lower than the Alpha variant. And the serum from the individuals who had received a single dose of vaccine were totally inactive or barely active against the Delta as well as the Beta strains. Now, as far as the monoclonal antibodies are concerned, there are 2 other monoclonal antibodies other than what I just mentioned, bamlanivimab and atezolizumab. The bamlanivimab had lost its total antiviral activity against the Delta strain because of the L452R mutation. Atezolizumab, casirivimab, and imdevimab remained active against the Delta variant. So in summary, the ones that are available in India, casirivimab and imdevimab, they are quite effective against the Delta variant. Although overall, if we see, then Delta variant is slightly more resistant to the neutralizing antibodies than the Alpha variant per se.
Thank you, Dr. Vivek. Now then, we come to an interesting question. At least in this country, we have 3 vaccines available. We have the Covishield, the Covaxin, and the Sputnik vaccines. Other countries may have had access to different other vaccines as well. So which of the current vaccines are more likely to offer protection against the Delta virus? We'll ask Dr. Mani this question first, and then we'll ask the same question to Dr. Vishnu. Sir, would you?
I think currently the evidence is is available for Pfizer, BioNTech, and for AstraZeneca. That I think these are basically in vitro studies to start with, and then also some data from the surveys. So as the Pfizer BioNTech protects from infection 83% of the time, and I think with both doses. And as far as AstraZeneca is concerned, it protects 70% of the time, but both of them protect from the hospitalizations and mortality above 90%. 95, 96%. So the protective effects in terms of the harder endpoints are better, are good, are maintained, but protection as far as the infection is concerned is acceptable, but it's not as good with Covishield as compared to Pfizer BioNTech. The the manufacturers of Covaxin, they give the data that it is protective against Delta variant Covaxin, and I'm not aware of studies on other vaccines at the moment. It may be Moderna, the mRNA vaccine in general, they are protective as of now.
Sir, I'll just extend this question. If somebody approaches you to advise on which vaccine should a national policy include to minimize the effects of the third wave, in your experience and with your understanding, what vaccine would you recommend?
I think we should have the Pfizer BioNTech.
Dr.
Because
Vishnu,
that has got robust evidence of protection.
Dr. Vishnu, your take on this, please.
Yes, sir. So when it comes to the severity, I think whatever the vaccines available in our country, if to protect against the severe disease, these are all more than 90% protective. But when it comes to the overall protectiveness, the variants, when it comes to specifically the Delta variant, it's Covishield and Covaxin, it's almost 65% effective against the mutant, that is the Delta. But when it comes to the Pfizer, it has the best protective evidence of up to 88%. When it comes to Sputnik, we don't have a direct study to say that how much efficacy it have against the variant, but we have in vitro data. Recently, an in vitro data has been published with the Sputnik vaccine, where they looked into the neutralizing ability of the antibody induced by the Sputnik vaccine. So, which clearly said that against the variants, against the alpha, beta, and the Delta variant, the vaccine, the neutralizing efficacy of the antibodies induced by the Sputnik vaccine is 2.5 to 3 times lesser. So definitely it is less compared to the wild strain neutralizing effect, but we don't know how much it translates into the clinical response. But when it comes to the Covishield and Covaxin, it is around 65% is the protection offered against the Delta variant. And somebody comes to me and asks what to be preferred. I mean, of course, the ideal one is the Pfizer, but that is not available. I always say Covishield and Covaxin are equally efficacious in terms of their efficacy. But when it comes to a lot of people are expressing their issues on this, the coagulation issue or the clotting issue with the Covishield. The data clearly says that the risk is 1 in 1 million. So, I mean, if we compare the risk-benefit analysis, it's the benefit offered is far beyond it. And these sort of clotting issues are not been reported with Covaxin, at least in the data. But somehow we are listening to the colleagues. It's not the data, it's not the published data, but few of the colleagues are saying that even with Covaxin, they are seeing few of the clotting issues, but it is not the data that's been published. Other than in terms of this one, I think efficacy is more or less the same.
Thank you, Dr. Vishnu. So now we know that the vaccines may not be completely protective. We know that the antibodies may not give us the kind of hope that we have put on them. So obviously it looks like containing the spread of the Delta variant is the only way we can limit a third wave. So somebody who's faced it and who's facing it right now is Dr. Morris. So let's ask him what he would advise us sitting here on the steps to contain the spread of the Delta virus. Is that really possible once you know it's more infective and transmissible?
So that is a very interesting and difficult question to answer. I think if you are in a position to keep a variant out of your locality, be that a country, a region, and so forth, then we can clearly see examples of countries that have done that and have done very well. So the obvious example would be New Zealand. Now, that is, of course, a position they were able to take, partly because of their geographical location, partly because of their resources and so forth. I think what we can see with the Delta variant is that it is more transmissible, which means controlling it is harder. And even in countries that are well-resourced, social distancing and the sort of lockdown type procedures that clearly are effective at controlling this virus, but the impact that they have is considerable. And so I think the answer is, unfortunately, that these viruses are going to continue to spread. We can only control what we can do, ourselves, I think, within hospitals, and we should be taking good infection control procedures here. And we're also increasingly aware of the ability for any form of the COVID virus to be spread in an airborne form. And therefore, that those who are looking after patients with COVID or those who are at high risk should certainly be wearing aerosol protective PPE wherever possible, not just in those areas of the hospital that are classically aerosol generating. How you translate that out into the community is I think, a much bigger question. And I don't think any country has worked out, once the virus gets in, how it can stop it spreading, very, very rapidly. Beyond really, it's social distancing, it's good ventilation, it's ensuring mask wearing in public areas and so forth. But each one of those things, they're all imperfect. And when you come up against a virus like the Delta variant, which is more transmissible, then a 25% reduction in transmissibility is great. But if your virus is twice as transmissible, then obviously it's a battle of diminishing gains. So I'm sorry to be a sort of purveyor of doom. I think the answer is to carry on taking the measures that we have been taking. I don't think there's anything special or additional that we can do. And I think the other thing is to watch out for where you're seeing outbreaks and to try to control them. Although, once again, countries have not been particularly good at that. And I think it's because it is very, very difficult.
Todi, sir, your take on this.
What I would agree with what Dr. Conway has mentioned, just as a few additional thoughts. How do these new variants have come into being? This is a very peculiar phenomena with so many new variants of concern. We know that with the antigenic shift and drift, there are variants, but most of them are not of that clinical consequences. One of the thoughts which have been raised is because of indiscriminate use of many of the measures that have been taken, even convalescent plasma and many other drugs which have been used, have that led to this variants of concern emergence. So one possibility is we have to restrict our use of all this different armamentarium onto a very scientific basis. Even monoclonal antibody, it probably blocks the natural antibody protection. If somebody is infected, you give monoclonal antibody, they are not mounting their own natural antibody. So using monoclonal antibody out of the context of its indications might create problems. So that is one aspect of it, how to reduce the additional variants. The second is probably we still do not have access, just like we have access to the SARS-CoV-2 test. We have no idea of which variant is our patient is being infected with, just the epidemiological evidence. But if you have different kinds of variants, it might be very difficult to know. So I think some kind of a genotypic test, which is also becoming more and more available, and genotype and phenotypic correlation will become more important. So that is the second thing. Third thing is how do we utilize the existing vaccines that we are using? How do we do research on that, on the variants? The first thought which have come is can we do kind of a randomization of patients, say, of different dosing schedules, of different dosing durations, of booster dose, or mix and match dose of different variants, and see whether that has got a clinical either a clinical effect or a surrogate marker which can reflect a clinical event. And obviously, in the end, we should have a new or modified vaccine which have got antibody, which will have antigens specific to these variants into their vaccine armamentarium. So many thoughts have come on how to deal specifically with these new variants. But I think most important will be utilizing our current vaccine strategy to study these variants will become very important. And also observational studies, breakthrough vaccine infections, as has been mentioned by Om and others, breakthrough various infections. But we have to know in which subset of patients this breakthrough are more common and which vaccines it is more common. So I think we need more access to this genotyping, and we need more observational studies to give us more information about these new variants. Over to you, Sima.
Thank you, sir. So I'll just take this question across again to Dr. Om, and I'll ask him, for though the country started its vaccination drive mid-Jan this year, and some percentage of the population have been vaccinated. And for those who are vaccinated in early January, February this year, is there a rationale for a third dose now, now that we are anticipating a third wave? So can we prevent a third wave with a third dose? Is the question topmost in the minds of a lot of people. Is there a rationale? Would you recommend? What's your take on this, sir?
I think I am not sure whether the vaccine is going to be able to prevent the third dose. Look, unless we have vaccinated up to 50% of the Indian population, I don't think we can talk about prevention of any, whether it's third or the fourth wave, if at all, either of those waves are likely to come. I think definitely there is a role for vaccination. And yes, I agree with you that ultimately the vaccination program is going to go on to a third dose and will require a yearly booster dose. And that the vaccine will then be like a quadrivalent influenza vaccine, which will have more than one component to the vaccine part. And that will be a yearly feature. But that is a little bit away from right now what we're discussing. As of now, I would think that given the kind of incidences that we are seeing of COVID, whether it is Delta, Delta Plus, or variants, or other variants that are likely to come our way, I think there is definitely going to be a role for a third dose, and that there will probably be, in the very foreseeable future, there'll probably be a role for recombinant vaccines that will combine a number of components that will cover the most part of COVID infection, and that will be a yearly or a twice yearly feature.
Thank you. Manish, what would you say on this?
Yeah, thank you, Srinivas. See, Srinivas, the data for the vaccine which are available in our country is definitely very difficult to say whether the booster dose is going to be there or not on the basis of the data which we have. As Dr. Srivastava has said, definitely it is something which is going to come with the passage of time. But the data from the vaccine which are outside this country, especially the Pfizer vaccine, if you go into the data, they have said that when they have given a third dose after the 6 months from the second dose, they have seen the strong antibodies response, especially 5 to 10 times higher from the baseline. So that has given them the confidence for giving this therapy, the third dose concept, and probably this is going to be revised with the FDA, and they have seeking the certification for the same. The same thing, if you see it for the Moderna vaccine, they are also talking about the similar concept, and they are particularly saying whether the third dose will be, is it going to be the same dose which was there in the second dose, or the third dose is going to be the half of the previous dose, or the third dose is going to be a dose which is going to be a modified vaccine, which will take care of the particular variants, especially the Beta and the Delta Plus variant. So these are the things which are coming up. The Johnson & Johnson vaccine, which is basically just a one single vaccine dose, they are also coming out with the proposition for the second dose. So by and large, the things which are there in this country, we still don't know, but outside data is definitely looks like, they are getting more motivated for, the third dose vaccine concept.
So, Dr. Mehta and Dr. Nangia, it looks like we are in for it, right? Sooner or later, we are going to be in for it. So, I know we have faced storms before, we have faced 2 waves, and we have learned some lessons, or have we? I'm not sure. So, what do you think? The healthcare delivery systems, how do we prepare ourselves for a variant? I mean, I know that Andrew is watching us and he knows how they are doing it. But what is it that you would suggest that we follow, or we change our way we are managing these infections or handling them and preparing for the wave of infections with waves of variants? Ravi first, and then Dr. Nangia.
Yeah, so Srinivas, I was looking forward to the fact that you'll run out of time and truncate this question to the minimum, because it is a nightmare to even think about it. And it comes down to what hats do we wear? Do we just talk? Do we just pontificate? Do we just, give our opinions in webinars, or can we actually do something when we've gone through so much? So when I was thinking about it, we recently had our own Karnataka debriefing. So it came down to a few things. One is, what can we do in 3 areas? Our local ecosystem, the place where you work and I work, what can you do to make a difference in that ecosystem? Whether it's a corporate hospital, a government hospital, a chain of hospitals, and so on. The second aspects of that of integrative, because we realized in COVID that it's pointless working in silos. It's the first time in the world, in the history of our country and the world, that we've seen people, government and the private sector working so closely together. So the integrative ecosystem matters. And thirdly, our cardinal roles, both as educators, preventers, and being the flagship people, or the lighthouse which actually guides people in the pandemic, because everything is helter-skelter, and the differential component of each part of society, including governments and all, has not been too great. So if you look at, looking at these 3 areas, and of course, let me not forget, your whole webinar is variant oriented. So is there something about variant related stuff which we can do in the healthcare system? And lastly, as was pointed out by Andrew, how can we make sure that the non-COVID work goes on? I mean, 1.5 years, we just can't push it to one side. We have to make plans that also goes on, and we just don't have a whole slew of people having cancers and so on. Lastly is the aftermath, what we call the epidemic after the pandemic. What we did in the second wave led to the largest numbers of mucormycosis in the world. So there's so many areas one can talk of. I'll try not to be exhaustive and take a minute or two and let Vivek add his component also. On all these fronts, I think the first cardinal thing is debriefing internally as an ecosystem, as a city, state, and country, about what can we do better, where did we lose it completely. And the first thing which came in the last wave was infrastructure, medications, personnel, and so on. So I think that's a major part of it. We can't have a country full of oxygen, but no oxygen at the point of care where we actually required it, as an example. So debriefing for all these areas would be extremely important, and we all have gone through problems. Second is not to work in silos. The claim to fame of Andrew and the UK is things like the recovery trial, which actually showed that an established research system could put research into place in a pandemic and give useful answers. So if we can not work in silos for both the delivery part of it, the research part of it, and the resources part of it, that would be really important. And we brought that up to our city people also. The third or fourth components are, third is, let's be simplistic and minimalistic in the clinical approach. The clinical approach has gone all the way from the infamous hydroxychloroquine all the way to gamma globulin or whatever. And we have to understand that very few things at the end of 1 year and 100,000 papers plus work in COVID. So can we be minimalistic and simplistic? So for both efficient healthcare, resource utilization, and not have panic in the lay population who run helter-skelter for drugs. And then lastly is work backwards. We all know that we have to ultimately save lives in healthcare. So can we look at mortality factors, work backwards, and complete the links of the chain, which will actually help us to do a better job in every way. So these are the aspects which come to mind offhand right away. I would not divorce or forget the role of civil society. Certainly at this point, our role as being telling people what exactly causes infection, exactly being how should they behave themselves. They listen to us much more. Involving volunteers, involving civil society when we are running helter-skelter for resources, and being advisors to the government. That also our healthcare systems can do. So a lot of words in a short span of time, many principles, but even if a fraction of these are done, I think we'll be better prepared for the third wave than we were for the second, because it was woefully inadequate when we came to the fact that we have learned very few lessons in the second wave from the first wave. So I think the long and short of it is learn, debrief, learn everything what you can from the previous two, be brutally honest and merciless with yourself and your system to try and keep things going and keep the non-COVIDs in mind, as well as have an extended circle of involvement with government, civil society, and the people.
Dr. Nangia, please.
Yeah, so being a little more specific to what Ravi has just mentioned, I think we need to work upon a few areas. Like, first of all, is manpower. This time, what did we face? We faced a shortage of manpower, doctors not being available, patients being turned back because there were no oxygenated beds, no oxygen being available. So how can we increase the manpower? So, towards the end of this pandemic, this wave of the pandemic, we started working on the non-pulmonary, non-internal medicine doctors to at least help us pitch in probably taking the rounds of the wards, in handling the OPD patients, those with mild illnesses, by laying down the protocols and sharing with them the protocols on how these patients can be managed, at least with those who have a mild illness. Similarly, training of the nursing staff, especially when you expect, more of the pediatric population to be affected in the third wave and the fourth waves. So probably training them on those lines would be equally essential. Then oxygen was a major constraint this time, where we had to refuse patients primarily because oxygen was not available. So manufacturing oxygen in-house would become very, very important, and probably should be mandatory for all hospitals of a particular structure to be able to do that on their own. More important than that is also to get the home care delivery services in place. Their doctors, their nursing staff should be adequately trained to be able to handle most of these patients at home, rather than, again, overcrowding in the hospitals and people dying just because they couldn't reach the hospital in time. So if we could get the insurance companies also probably to pay up for this home care services, I think that will help a long way in reducing the number of patients barging into the hospital. And ultimately, I think e-ICUs would be a good idea too. In our country, we still lack ICUs with proper e-facilities where they can be monitored from a distance, where even when you're at home late night, you want to monitor somebody rather than going back to the hospital, wearing a PPE and going inside, which may take a couple of hours. And e-ICU may just be a good concept to develop in most hospitals. So that's what I feel, we should be prepared for any kind of a pandemic in future, not just this one, but any other pandemic too.
I will take a few questions which we got in our question and answer boxes. Three issues which we didn't address because we were focusing on the variants, the vaccines, and the immune response. First thing is something which you raised in children less than 18 years who are not vaccinated. Should they be allowed to go to school, or is there some other alternative precautions? So I'll ask Dr. Nangia to answer this, and then we'll ask Dr. Srivastav for his views on this.
See, basically, children are very potent carriers of all these viruses back home. But at the same time, you just can't keep the schools shut for an unlimited period. So there has to be some deadline somewhere, and there have to be certain precautions that need to be followed, certain policies that need to be implemented. So even at the school level, if you really see, any child above 5 years of age can easily wear a mask and go to school. Schools probably will have to have certain guidelines of their own, like probably having segregated timings of the students coming in, probably have half day morning, half day evening, have half students coming on Monday, Wednesday, Friday, the remaining half coming on Tuesday, Thursday, Saturday. Something of that sort will need to be worked out sooner or later, because this can't be indefinitely shut.
Okay. Dr. Srivastav, please.
See, again, if you look at what's happening around the world, Singapore has virtually made a policy that we are not looking at zero transmissibility. We are simply going to treat COVID as a community-acquired infection. If you look at Israel, a lot of the people that I know who are living in Israel right now are simply told that, look, if you follow these precautions, you can be on the streets, you can go to cafes, you can eat and drink. In some parts of the United States, like say California, they've done pretty much the same thing. So, as Dr. Nangia has rightly pointed out, you will have to try and see what can be done to get back to normalcy. Now, children are going to be high risk, but if you keep enough distancing in class, And if you make an alternative, plan of people coming at different days of the week to school and keeping a very strong vigil on even a small minor outbreak, I think it can be done, but at some stage you'll have to bite the bullet and get on to doing what you need to do. But it's going to require a great deal of planning, a great deal of execution, and a great deal of follow up in public health before you can say that yes, we are back to being at least half normal.
One more question is about COVID and pregnancy. So how has pregnancy, the COVID infections in a pregnant lady differed in the first wave, the second wave? I would probably ask somebody who has seen the third wave as well. We'll take it to Dr. Andrew and ask him, has he seen any difference in the way the pregnant ladies have behaved with COVID infection in the first wave, the second wave, and what he's seeing now as part of the third wave?
So we've definitely had a few pregnant ladies through the hospital and through the intensive care unit, and they've been across the second and third wave. From memory, I certainly don't recall any in our hospital in the first wave. And looking at the data in the first wave, I think it was less clear. Now, whether that is because there's genuinely a difference, as I say, I think we can see first wave in the UK was pretty much wild type virus. Second wave was the Alpha variant. Third wave is the Delta variant. Whether that difference is because of the variants or because of the groups of the populations that have been affected, I think it's probably more the latter than the former. I think the epidemiology tells us pretty clearly that women who are pregnant who have the same age and comorbidity profile as a woman who's not pregnant are at increased risk of severe COVID. I think that's pretty clear. But it's still the case that the vast majority of women who are pregnant who get COVID, who are young and usually don't have many other comorbidities, will be absolutely fine with it and will not require critical care, certainly, and most of them will not require hospitalization. I suppose the other thing that is with pregnancy is always the case of the sort of interactions with medication. And whilst it's pretty clear that steroids are unlikely to be harmful to the fetus, particularly if it's at a relatively early stage where it may help accelerate fetal lung maturation, there is reasonable evidence that tocilizumab can precipitate miscarriage. And so clearly there's a difficult decision to be made there when you've got a pregnant woman with severe COVID, which therapies you offer them. And where possible, it should be made with the mother involved, where she retains capacity. And I personally find those decisions very difficult and generally involve colleagues, to get advice. And then ultimately we have to go to the patient themselves and say, look, this is where we are. These are the options. But yeah, no, it is a problem, but it's not like H1N1 in 2009, where there seemed to be a real problem with young pregnant women coming into the ICU. I don't think we've seen that here in large numbers.
Ravi, would you like to say something on this?
No, not really. I think Andrew's put everything into perspective. It's been a massive challenge. The postpartum period has been a second challenge. Recently, we had a couple of people with that aspect where the post-pregnancy changes and the way they go sick. So as they're barely recovering from that, when they're probably more susceptible to COVID, they get severe forms of COVID, they were not vaccinated, so presented a particularly challenging subset to deal with. A couple of points on the last issue also you brought up about opening up. The recent NEJM article brought out 2 extra things that focus on crowded areas, very important in our country. If those can be targeted, and nothing worse than Hyderabad, Mumbai and Delhi and all, where those are going to be the hubs of spreading. We know about your dynamics in your cities and our cities similarly. And the second is they come up with this interesting word called vaccination rings, that to open schools, can you create the ecosystem where parents and so on and teachers are vaccinated with all the caveats of vaccination to try and make it a more safe environment. So these 2 aspects were further highlighted in the NEJM recommendations on SARS-CoV-2 vaccines and so on.
Thank you. Andrew, are you seeing a lot of kids coming in with infection as of now? Are you seeing a lot of pediatric population as of now? If so, how are you managing them? They are not very compliant with the BiPAPs. They're not compliant with the HFNC. So how are you handling this?
So I have to confess that in our hospital, pediatric intensive care and adult intensive care are 2 completely different groups. And although we share a floor, we sometimes even struggle to talk to each other. So my understanding from having talked to my PICU colleagues is they haven't seen very many cases. And that they are managing them in the same way as they would children with acute respiratory failure from any other cause. I think what we have seen is a reasonable number of cases of children with this multi-system inflammatory syndrome. And they tend to be older children. So we're not talking babies, but more, sort of children in the early teenage to mid-teenage years. And that tends to be developing, several weeks after COVID infection. They have a particular cardiac phenotype. There's some suggestions, although it's not based on strong evidence, that tocilizumab might be useful in that group. I think what we're seeing though with those groups is that they are in relatively small numbers. Even in the UK, we have a relatively small number of pediatric intensive care units, and they tend to centralize complex cases from across regions. So I think we can definitely say children are getting sick with COVID. That is clear. They are much less likely to end up in hospital than adults, and they are much less likely to end up in intensive care. But again, I think we will see this as cases rise in this country. A small proportion of a large number of people can still be a large number of cases. And I think the other thing that we're seeing is as the social distancing that was in really quite strict lockdown here earlier on in the year is lifting, we're starting to see spread of other diseases that were adequately suppressed by that social distancing. So we're seeing a lot more RSV, and that's coming at a funny time of year. We don't usually see RSV at this time of year. We're seeing a little bit of flu, although not very much. And we're also seeing, interestingly, some norovirus, which again is something that we usually see in the winter. And we've obviously got, particularly at the younger end of the pediatric spectrum, we've got a group of babies who are now becoming toddlers who simply haven't been exposed to seasonal colds. But very, very few for a year or a year and a half. And so that is undeniably putting pressure on emergency departments. And of course, now every time a child gets a fever, the parent is obviously concerned that they might have COVID. And so I think there's probably a lower threshold for presentation to healthcare. And again, that's causing trouble, even if the children don't have COVID. So it's really complex, the interactions between disease, society, and medicine. And it's not just a simple case of it's one disease, it's one variant.
Mani, sir, your take on this, sir. You would probably be the best person to answer this.
Sir, you are muted.
On the my take on the children's side, yes, what I've heard from my pediatric colleagues, as Andrew told me, told us that it's not we don't really overlap much with the pediatric age group, but the pediatric colleagues have seen a surge of multisystem inflammatory syndrome, and some of them requiring critical care. So although there have not been RT-PCR positive cases who are very sick, but there is a coexistence of MIS. So there is a tantalizing, we know that there is some kind of relationship, we don't know exactly what. Whether we are going to have RT-PCR positive cases of children, which will impact on our critical care, pediatric critical care, it remains to be seen. It's not happened so far in our country. And elsewhere, the experience has been more of MIS, I think, what Andrew has mentioned.
Yes, sir. So we have one more question, and I'll pose it to you, sir. What about the breathlessness of these patients? So quite a few of these patients seem to be breathless for a prolonged period of time. Even after they have come off oxygen, they tend to be breathless, either at rest or on minimal exertion. Now, how are you, what is your suggestion on how long do we support? What is the expected time frame for them to get back to normal lung capacity? What is your take on this? There's a question posed on the Q&A.
See, the Delta variant appears to have greater affinity to the lung tissues, and there's an earlier presentation of the pulmonary manifestations. That's one thing. And there appears to be, in a subset of patients, a very prolonged course of respiratory failure. They get into a state of prolonged pneumonitis or of fibrotic inflammation, and it's a sort of a chronic state of hypoxic respiratory failure. Now, how to deal with them? I mean, there are no clear guidelines. Whether we use steroids for how long is unclear. but majority of us use a prolonged course of steroids, not a high dose, but modest doses, maybe 20 to 30 milligrams of prednisolone or 0.5 milligram per kg of prednisolone for a variable length of time. I mean, it may be for a few weeks, monitoring the progress. The role of antifibrotics is not clear at all. Although there's been a lot of overuse of antifibrotics, I personally do not recommend it because anyway, antifibrotics are not known to act in the acute stage or in the short term. Their role is to reduce the decrease of FVC over a period of time in idiopathic or immunological related ILD or IPF. So antifibrotics are off-label use as of now. Whether we can use pulse steroid therapy in these patients, I think there's a subset of patients who are exacerbation of a baseline ILD, on top of which they've had COVID, and then they've had a superimposed COVID pneumonia on it. Now, those patients are a candidate for pulse steroid therapy, provided you exclude infections. Now, infection mean not just bacterial infections, of course, aspergillosis. We know there is a higher incidence of aspergillosis, as we had with the H1N1, we have it with COVID as well. As far as mucor is concerned, I think that's another big threat with us. I'm not very sure it's all related to the virus. I think mucor may be related to the therapies that we have been using. We have been very liberal with the use of steroids in the dosage, in the timing, and in the duration. We have been very liberal in the use of pulse steroid therapy. We've also been very liberal with a lot of multiple antibiotic therapy. So they all combine and immunologically intervening therapies, right? What we do with plasma therapies and IVIGs or tocilizumab exactly is not being worked out in the immune system, and how they're going to impact on unusual infections and opportunistic infections is an open question. So whatever we do, we must be aware what harms can be done. All right. So it's very easy to write a prescription and to take this as an excuse to be more liberal with our therapies, but it has to be tempered with a thought that we could be doing more harm than good. So I would say we have to play it by ear when you are dealing with a subacute or chronic hypoxic failure due to COVID. You can use steroid judiciously, but time may be really a process which will result in a reasonable outcome of remodeling and rehabilitation.
Thank you. I now request Dr. Deepak Govil to give us the take-home message from this panel discussion.
No, it is a difficult job, Dr. Srinivas. I would request you to give the take-home message.
I will actually leave it to the panelists. I will ask each of the panelists.
Yeah, that will be much better. But in between, I am just interjecting a small question.
Yes.
I'm sorry to take up this question. It's not related to this discussion, but as Dr. Manisar has rightly pointed out, there is an increase in aspergillosis and mucor. What your take on is for CMV reactivation? Of late, I have seen 5-6 patients who are having high CMV copies. So although it is just an offbeat question, not related exactly to the topic, but just because I saw that so many specialists are there, so I was just tempted to ask this question. Anybody?
I think CMV is also has also been reported now. That's what I'm saying. When we intervene so heavily with the immune system, in fact, one of the biggest problems has been this definition of cytokine storm, which is still very nebulous to me, right? Cytokine storm has been a buzzword, so it has also become an alibi to use many therapies and in multiple combinations, which we have never done before, right? All sepsis is a cytokine storm, but we have never used these drugs before. How it is different from the previous cytokine storm, I do not know. But this time round, I think it has triggered a sort of a hyper response from the medical profession, in terms of therapies and interventions. So there's been equally injurious, I think. And we have also injured the lung tissue with a lot of supports, right? We have used NIV and HFNC for very prolonged periods of time. And we have intervened in intubation rather late. So what we have done in terms of self-induced lung injury, we do not know. So there's a combination of many things which are thought-provoking, and we have to take a good look at ourselves whether all of what we have done is justified.
Sir, your take-home message, sir.
No, Dr. Mehta want to say something, then we'll have a take-home message.
Yes.
Very quickly to answer your question, around 100 bronchoscopy samples in critically ill patients, the subset you're talking about in both waves, 2 CMVs, viral inclusions wise, and they were hunted down with further viral copies, which were just not too much. So not a lot. Not a lot is the answer. You've seen a little outlier syndrome. It is a signal, but currently, at least with data, it doesn't seem to be overwhelming.
So, well, it could be a coincidence that I have seen 5-6 patients.
So we've also seen about 4 such patients of CMV titers being very high. So it's not that it's a coincidence. It is happening, except that it's still under probably not every one of us is testing for CMV yet. But once you start testing, I guess we'll also start finding them.
Yeah, we also have a good number of CMV cases. These are all biopsy proven. In fact, our case series, we have almost 8 cases of CMVs, out of which one of this interesting presentation, where this hemorrhagic bronchitis. There are a few of the patients who just bled from their bronchi. The visual appearance is consistent with hemorrhagic bronchitis as by my pulmonologist. And when we actually biopsied them, we have the CMV inclusions. This is something which not been recorded anywhere. We didn't even see any case reports. But there are 4 or 5 cases like that. Clearly, it's full of the bronchus, it's full of bleeding. And when they actually biopsy, this is what they found. And we had 3 to 4 cases of cavitary pneumonias, which turned out to be aspergillus plus CMV on biopsies. And mind you, a good number of people are actually diagnosing CMV based on the viral load, which is not the case. The diagnosis of CMV should be based on the biopsies, because even a sick patient, even a normal ICU patient can have a high CMV viremia. That should not translate into a CMV disease. It has to be the inclusion bodies to be demonstrated on the biopsy. But yes, definitely you are saying the GI CMV we have seen, and we have seen the hemorrhagic bronchitis and the cavitary pneumonias coexisting with aspergillus on the biopsy with the CMV inclusions. We are seeing more, yes.
Thank you very much. So we can start with Dr. Andrew for take-home messages.
Quick take-home message, Andrew.
Yeah, quick take-home messages.
Thank you very much. I think my take-home messages would be, first, to echo what Dr. Mani said, is be careful of the harm that we may cause and stick to what the evidence base tells us. We've got good evidence base now for immunotherapeutics, and beyond those, we should be very cautious. My second take-home message is it's less important what the variant is as being prepared. It's learning from the experience that we've had before and thinking can we cope with large numbers of patients presenting in a very short period of time. So getting the infrastructure right, I think, is more important than a specific variant.
Dr. Mani, sir.
I would say that for our country, the important thing is at this time, we have to drive the vaccination program as high as possible. We cannot expect social change, behavioral change to take place quickly. What is in our control, there are 2 things which are not under our control. That is the emergence of variants, okay, and the transmissibility and the infectivity and the lethality of the changing patterns. What is within our control is to scale up the vaccination program. What is within our control is to reduce the transmissibility through prevention of congregations as a policy. Okay, individual citizens we may not be able to control, but we can control our policies. So I would say we have to be prepared, as Andrew says, and this is the way we should prepare.
Oh, thank you, sir. Dr. Srivastava, sir, your take on.
Okay, so some points are going to be repeated. I'm not going to dwell upon them. I think as clinicians, we are all clinicians. I think as clinicians, we need to do our basics correctly. We don't need to overdo that. If we treat the people who can be treated at home, they should be at home. Those people who need to be admitted may go to a COVID care center or to hospital, depending upon their illness. One, as Dr. Mai has rightly pointed out, vaccinate, vaccinate, vaccinate. It is very difficult to do the tracing that we did in the first wave. I think that we probably need to accept that COVID is not out of our lives, not going to be out of our lives in the very foreseeable future. And let us follow the first principle of medicine, and that is do no harm. So that includes the things we have discussed about biologicals. If you don't think it's going to make a difference, there certainly isn't a role for biologicals or remdesivir or favipiravir or hydroxychloroquine, whatever it is. If you know that there is evidence that it helps, only then use it. Otherwise, COVID will recover even with good intensive care. It does not need anything else except supportive care. Oxygen therapy and good intensive care may make all the difference that you're seeking with any other agent. So I would say do no harm and keep the basics of medicine correct.
Thank you, Dr. Srivastava. Dr. Mehta.
I think in addition to all the extremely good points already made, I think the healthcare infrastructure lessons from the first two waves have to be looked at, debriefed, reiterated, reinforced, and gotten rid of so that we are empowered better. Second important point is take care of healthcare personnel. They're going to be really valuable. We were the ones who got vaccinated the first. We'll be the first one to go through breakthrough infections, need for third shots, and so on. So that would be very, very important as a short and long-term exercise. And the last 2 points is don't work in silos. We need to form partnerships with each other as well as with, as I said before, other volunteer organizations and civil society so as to empower the whole system and create infrastructure for Indian research and sharing of knowledge, which is something which we can do much better because as a country, we have so much going on, but we need to make these things come out fast like the UK has set the stage for.
Thank you. Dr. Nagia, please.
So I think it'll be repetition only majorly that, we have to understand that this virus is here to stay and is not going away anywhere in the near foreseeable future. So we need to be prepared for it. Do not let our guards down. We need to keep motivating our colleagues, friends, society per se to get themselves vaccinated and follow all possible precautions that exist so far, follow the COVID etiquette that it's come to be known as. And as far as the medication is concerned, we still don't have any magic bullet to treat this virus yet. So even the monoclonal antibodies have a very, very limited role. So do not rely on anything other than basic medication that you could use for your patients. And I guess home care services also could be developed further. That is one area that we could work upon. And whatever infrastructural or manpower issues you faced in the previous epidemic, in the previous wave in your own institution, probably that is something that you could work upon and develop for the future. One doesn't know how the future would be, but there's no harm to be prepared for the future and work towards it.
Thank you, Dr. Nagia. Dr. Vishnu Rao, what is your take on?
Yeah, I think it's vaccination, vaccination, vaccination. Other than that, we need to establish a good surveillance system on identifying what are the strains currently there in the community. If at all we have the new strains emerging, we need to have a tight surveillance system and warn accordingly. Probably this is something which we are lagging or where actually this Delta variant has been identified much earlier. Probably this is a learning lesson, what I feel. And in the time to come, probably we need to have robust surveillance system to identify this sort of variants and of course vaccination. And this is what is my take on.
Thank you, Dr. Rao. Dr. Manish Bharti, your take on? You are on mute, please.
Yeah, thank you, Govind sir. I think majority of the things have already been covered up so nicely, but just to add, I think we are in the era of cognitive overload, where we have a lot of information, a lot of treatment strategies. We really don't know what is going to work and what is not going to work. So it's a time to give a pause, to reassess, reconcile the data, what is available, how effective it is going to be, and we need to practice according to the evidence-based practices, according to the given the infrastructures and to given the specific local bodies, and that's it.
Thank you very much, Dr. Srinivas. Would you like to add up something?
been a fantastic, enlightening discussion, and points which we never expected have come out of this discussion. I appreciate the time and the efforts spent by all the panelists. Hope we are all safe, and thank you very much for joining us on the Sunday evening, and enjoy the rest of your Sunday. Have a good day, and on behalf of the ISCCM, our deep gratitude for all of you.